right, well, thanks, everybody. I'm going to give you this one. Okay, good. And we will get. It's one of the great things about working with the Bridge Project. They're sort of partners of ours, is that we get babies to come to all of our panels. So I don't know. I think we learned a lot, or a lot was raised during that conversation. Hi, baby. Hi. So now we have, let me get my pages here. Dr. Omolara Thompson, you're giving me Thomas, you're giving me a break in her wonderful, beautiful African name, which I will not make it through at this particular time. Thank you so much. Of Strong Children Wellness based in Queens. Allison Lake, all right, who is the executive director of Westchester Children's Association, if I can read my own handwriting here. We have Luigina Rosario and partner of the Bridge Project. Thank you so much. And we've got Zach. Zach, let me make sure I've got your name here.
Zach is good. Zach.
All right.
Yeah.
Thank you very much. Who's with the you operate. Why don't we start?
Public Health Solutions.
Yeah. Why don't we start with you, Zach? If you could tell us what you do in your organization, and give me just a minute to get my notes together.
Hi, everyone. My name is Zach Hennessy. I'm the Chief Strategy Officer at Public Health Solutions and Executive Vice President of the Whole U NYC network, which was recently designated as the Social Care Network for Queens, Brooklyn, and Manhattan. This was what Dr. McDonald was referring to earlier under the 1115 Medicaid waiver, which is to address the social drivers of health, to better address the social drivers of health within the Medicaid program.
Great, Doc. Why don't you give us the work that you're doing in Queens as well?
Yeah, I think some of you remember me from earlier today. But once again, I'm a pediatrician. Strong Children Wellness is a reverse integrated practice. So we partner with community-based organizations and under-resourced communities and provide different levels of integration of medical care, mental health supports, and social care coordination.
Great, Allison. And then we're gonna work our way back and can talk a little bit more about each.
Great. Good afternoon, everyone. Allison Lake. I'm the Executive Director of Westchester Children's Association, which is a multi-issue children's advocacy organization based in Westchester County. Our offices are in White Plains. We work on policy, legislation, and budget, both at the county and state level that impact children, youth, and young adults, and have been involved in the child poverty piece as a member of the governor's Child Poverty Reduction Advisory Council, which we'll get to some recommendations later. Thank you.
Thanks, Frank. And Luigina, as we've explained to us, you are a participant in the Bridge Project.
So my name is Luigina. I'm 26, was my first daughter. I am one of the moms participating in the Bridge program. This program has been a huge blessing to me. 32 weeks pregnant, I did have a huge complication going on in my pregnancy, which resulted in me having an emergency C-section. And at that time, I had absolutely nothing ready for the baby. So the Bridge was able to help me get clothes, Pampers, everything that I needed, the crib, strollers, absolutely everything. Another great thing, she was in the NICU for 22 days after being born, and I live in Brooklyn. She gave birth in Long Island. I gave birth in Long Island, so it helped so much as far as gas and everything that I needed for the baby. And it still is a huge part. It helps so much. I'm really grateful for the Bridge.
Right. And we love the Bridge Project, and Holly Fogel, who started it all as a private philanthropist, giving cash benefits to mothers in my neighborhood, actually, in the Hamilton Heights, Washington Heights neighborhood in New York City. So, we love this project. Allison, why don't you start with us and explain in more detail what it is that you do? And we were talking a little bit earlier about Westchester County. Whenever you hear that, most people think, oh, this is the swimming pool, you know. What could we be talking about poverty about?
Right.
So why don't you?
Yes. So thank you for that. And so at Westchester Children's Association, we base our advocacy on data. I have brought with me today a data bulletin that we do every other year, and a more recent fact sheet that we produced looking at poverty in Westchester County, because as much as people want to think that perhaps poverty is sort of a downstate or only a city concern and problem is throughout New York State, as some of the other speakers have said during the day, but certainly in Westchester County, which is one of the wealthiest counties in the country. But at the same time, there is certainly poverty, and our families are struggling. What I think I want to talk about a little bit is we, with some support from the Robin Hood Foundation last year, held some focus groups of low-income families that use government programs. We partnered with our federally funded health centers to help identify the families. And the pieces that came up were the stresses that families face in making ends meet. And we ran out of time because I was going to ask a question this morning to the doctor and others about the mental health stress. I mean, that was like the number one piece that we heard from families, just that stress of getting through the day, working 2 or more jobs, or even our families that are in shelters in Westchester County, families that are in shelters, they work and they pay to be in the shelter. I'll never forget a mom who said, I have to pay to be in poverty. That statement has really stayed with me, because here they are in a piece. The commissioner was talking about access to food. I didn't even know in my own community in White Plains that depending on like what floor you're in the shelter, you may or may not have access to a kitchen to prepare meals for your families. Any of us that have children know how picky children can be and what they will eat and not eat. And so this is just part for us, understanding the day-to-day, finding out what your kids will eat, what you're able to give them, getting them to school, and living within this sort of cycle of poverty. And so the focus group was really instrumental, I think, in lifting up the mental health of the parent, but also of the child. And often they said that their children go to school, perhaps have behavioral problems, and it's this vicious circle and cycle that they are in. Can they get them to a behavioral specialist, speaks the language, culturally competent, all of those things that we have talked and touched upon. And so for us, that the advocacy really has to happen at that systemic level. I love what you said. I took back, justice versus liberation. As advocates, we're all about, dismantling those sort of systemic pieces of racism, but that idea of liberation and empowering the parents, giving them the cash that they need, they know what's best for their families. And so I'll speak a little more about the recommendations that are coming out of the council, but it really is about putting cash in the pockets of families and letting them make the decisions that are best for their families. And we see this in Westchester and beyond here in New York State.
Yeah, absolutely. And to expand on the racism part of it, I heard a lecture recently, the Derek Bell lecture at NYU, where the lawyer was talking about working with children in trouble, as their legal representative. And she had been doing it for years. And of the hundreds of children that she'd had to deal with, only 2 had been white. Everyone else was a Black or Latino child that had been deemed to be somehow unmanageable and had been sent off for detention in the legal system, though, not just in some other. Doc, can you talk to us about that in terms of what you've seen?
Yeah. So I mean, what we do know is that it's not limited to that. We talked earlier about the child welfare system. We know the proportion of the population who is Black and Latino. And then we know it's almost 3/4 who represent, or Black and Latino represent, the children who are engaged in the child welfare system. And so ultimately, I think the issues that are at hand are really around what we can do as providers in the clinical setting and also getting outside of it. So one of the things that has been our mantra in terms of starting our work has been health begins in communities, not clinics. And so the idea for us, which was not, I don't think, rocket science, was if 80% of what affects the children that I'm tasked to take care of, that I made an oath to take care of and change their health, if 80% of what fixes that is outside of my clinical setting, why am I in here? Why am I spending 80% of my time in here? And so ultimately, I think it warrants for us as healthcare providers to say to ourselves that our work, and this was not how we were trained. So it is, once again, more unlearning, that our work really needs to leverage the communities that we serve, and not just saying that the direct care that when they come into our office is sufficient, but being able to understand what their experiences look like. And that can happen in many ways. I usually think about in my clinic setting, and now I've expanded this model to how I just engage around health, but first starting with engaging your patient, which sounds like that should be what's happening. But I can tell you how many patients, especially those in poverty, feel like they are going into a factory when they go into a medical care system. Number one, can you come into the room? And then ultimately 10 minutes later, they're out after using their whole day in the waiting room, and they don't know what the doctor said. They were given information and they feel that the concerns they had weren't even addressed. The second part of it is then moving on to being able to empower our patients. And what that means is empowering the staff members with actual information that is meaningful and tangible and at the forefront for our patients. So yes, you can tell them about all of this anticipatory guidance about what foods to eat, but where are they getting the food? What can they do about the light bill that is due?
Right.
And who do they need to call because they just heard that their family member might be potentially deported? And knowing what these resources are is really important. The third thing I say is establishing connections along with that. So thinking outside of our clinic, getting out and figuring out who is the community partner who does this work. Our patients keep asking about food insecurity. Who are the partners that we have? And the last thing is encouraging action. So I did an immigrant know your rights talk yesterday for our staff, because ultimately we feel like those are going to be the first people, not the only, but the first people that they are going to engage in attacking and testing if we say anything and if we actually protect them.
Yeah, you and I were talking about our experiences in Africa, and I'm on the board of AMREF Health Africa that serves about 35 African countries. We have a staff of 2,000, but what we've done, through these many years is train community health workers, thousands of them. And that is the way the health gets delivered in a very personal kind way.
Yeah, we actually are really excited. So we have all sorts of people in our clinic. It's not your typical clinic. Community health workers are part of our staffing. And recently we have now some money, I won't say it's enough, but some money that actually reimburses our community health workers to go in and do this kind of work, which really was templated after the work in under-resourced, low-income countries. Yeah.
Right. Zach, what do you have to say about all of this? We've given you a full plate.
Yeah, thank you. I'll tell you a little story about me and then a little story about Public Health Solutions, the organization that I work for, and then a little story, a picture of a potential future. In 1978, when my mother was pregnant with me, they detected an abnormality with her heart. And they advised that she seek a specialty care, see a cardiologist. She never made it to that cardiologist. 5 years, she was uninsured. She and my dad were unstably housed. They had mental health challenges. And 5 years later, when she was hospitalized for that heart condition, she had to have emergency heart surgery, which she did not survive. So I was 5 years old when I lost my mom. Shout out to I was very fortunate to have grandparents. Shout out to all the grandparents out there raising kids. That's an incredible protective factor and asset for very many families. Of course, I had trouble adjusting as a young person. So I myself also, that economic presentation we saw earlier, crime and drugs, all the developmental sequelae, as we say here at Columbia, were true for me in my experience. And that's why it's so wonderful today that I get to work for the organization Public Health Solutions. We've been around since 1957. And the organization does incredible work across the 5 boroughs in maternal and child health, sexual and reproductive health, food and nutrition, access to benefits, smoke-free housing. And we partner also with the health department to ensure that the social safety net, the organizations that constitute the community-based organizations that support local communities, have efficient and effective contracting and payments. That I wouldn't want to say that they work well because we're talking about government funding, but we help it work better for those organizations. And so we strengthen the community in that way. And so that's the story of Public Health Solutions. And then when I arrived at Public Health Solutions, I had a background working for healthcare systems. I was I was part of a merger that happened in healthcare, and many things happen during a merger that can disrupt people's care. And I also worked for a small safety net hospital in Brooklyn, where when all you're receiving is Medicaid revenue, you can barely keep the lights on, let alone provide a quality healthcare experience. So I was thrilled to come and work at Public Health Solutions, where health equity was the vision. And with that background in healthcare and seeing the incredible work that Public Health Solutions did, and knowing that resources were being focused more on the federal level on the social drivers of health, I thought this is an incredible organization that knows how to provide many of these services in the community, but also can administer contracts and payments for organizations that work. So we started Healthcare Community Partnerships, which has 2 big blue sky goals: our whole UNYC network, which is now a social care network. First, transform health insurance so that it is more responsive to what people actually need to achieve and maintain good health. So this is purchasing an air conditioner for a family that has a respiratory condition, mold remediation, rental assistance, eviction prevention, non-medical transportation, home delivered meals, things like that. Second, with this investment through the Medicaid waiver, it requires that community-based organizations who are going to provide these services through the Medicaid program be connected via technology for real-time collaboration and real-time communication. So our second blue sky goal is, let's modernize the social safety net. We take it for granted that we can pick up our phone and every transportation provider is on there through the Uber app. Every restaurant, large and small, is all there on Seamless at our fingertips. Wouldn't it be incredible if one day people could access the incredible resources of community-based organizations in a similar way? So yes, I am constantly worrying about the vulnerable situation we're in with the current administration, but I have these wonderful blue sky goals to keep me going. and give us hope.
Well, we wish you the best of luck with that. You have to assure that all of the clients have access to internet as well, right?
Yeah.
That I mean, that's a major issue in terms of accessing all of, all of that. Thank goodness they reopened the libraries and,
It shouldn't depend on access. It shouldn't depend on access to internet. You need to create multimodal access.
Right.
And have the workforce additionally be an extension of technology.
Great, great. Thank you for that, Zach. Great. I want to get back to Luigi. Tell us about what your life is like on a day-to-day basis now. I know you've given us the story of how you two managed to, to make it, but what are your plans and all of that?
Well, right now I am going to school for nursing. I'm looking forward to become a NICU nurse. Every day I get up, I work from home. I don't have to worry about childcare. I have the bridge there because even though I'm working from home, it is pretty difficult with the background noise. So, yes. So I am able to afford childcare as well. I know that when it comes to school, if I need help with books, I could count on the bridge as well because books aren't cheap. When it comes to food as well, I try to do like a lot of healthy eating, and healthy food is not cheap. So with premature babies, they are at risk. Like they're easier at catching asthma. So I try to do a lot of like juicing, and fruits and vegetables are not cheap. So yeah.
So were you able to get housing assistance as well?
Yeah.
And so tell us about that, because that really is a key.
So with the housing assistance, they did offer me it, but I am living with my parents right now.
Right,
But with the housing assistance, they did ask me if I wanted it. I didn't take it for now because I do
Right.
want to get the extra help for school and all.
right.
But it was
Oh.
there. It was an option. I don't know really much on it because I didn't take it, but it was an option.
Great, great, great. Well, look, we have the evidence of things working out well
Yeah.
here. Allison, again, you have some recommendations that you're,
Yes, I just
Working.
want to make sure that the audience is aware of the Child Poverty Reduction Advisory Council that Governor Hochul put in place. It's almost 2.5, almost 3 years ago. Kate is also one of the members, and we have been investigating many of the sort of big silos that we've talked about here today in terms of housing, in terms of cash assistance, early childhood, childcare experiences, et cetera. And the council, it's December, should be releasing our sort of final recommendations this month. And so I urge everyone, I know there's a sticker of the New York End Child Poverty website, to really stay in tune with that, because it is going to take all of our advocacy to really push the governor to put this in place. So the big bold goal, the big blue sky, right, to reduce child poverty here in New York State by 50% is going to take policies, it's going to take administrative reforms to make that happen. And so that the council, with modeling by Urban Institute, has looked at some of the ways that we think we can get to that 50% reduction, starting
that's
with
by 2032.
by 2032, that's correct.
Okay.
And so it's starting with, and I'll just sort of talk about three. Well, one is the Empire State Child Credit, which was, again, I know sort of talked about earlier, and that last year we were successful in at least getting families with young children under 4 to qualify for that. We're still pushing to say that all families should be entitled to it. It's sort of mind-blowing to me, and such not common sense that you can say, oh, a family is so poor that you don't get this credit. It's like, how, in what math does that work? And so really pushing to make that eligibility and to increase what families would get to about $1,500 for families. Again, we had this sort of laboratory during the pandemic of putting money, as you said, in the pockets, and it raised children out of poverty. So we know it works. It really is that political will to get it done. And so we are pushing for, as I said, an increase in the child credit. In addition to housing, the other big issue that all of us I know have spoken about, and it touches so many lives, is offering housing vouchers, right, to qualifying families at a level that makes sense for New York State. Again, I'm here from Westchester County. The cost for housing in some places here in New York is just really off the board for people that are, again, you know, working every day, paying taxes, et cetera. And so to be able to offer an increased housing voucher to families is another piece that we're looking at. And then in addition to cash assistance for qualifying families. I am learning a lot on this council, as I said, you know, when you're doing multi-issue advocacy, I tend to sort of, you know, I'm focusing on this and then I move over there. But when you hear things like, you know, it's been 12 years since there's been an increase in the amount of cash assistance. And any of us going to the grocery store 12 years ago versus now, you know, sort of knows the increase in that. And then really, I think that the lesson, again, coming out of the pandemic is as much as possible, sort of pinning these things, indexing them to inflation so that we don't find ourselves, you know, 3 years from now in the same time saying that we're just not keeping up with the expenses. And so to move that from, you know, a family of one child and one adult at this point is like $300, is that right? Okay, to trying to move it to, you know, like 1,500. Again, and we're not talking about a lot of money, but it is money that would go into the pockets of families. And I just want to reiterate that what has been said about giving families, giving adults what they know is needed for their children. I just think that that has to really be our starting point on all of these pieces of the recommendation. So, you know, that should reduce all of these three things together, get us to that 50% number by 2032. But it's not a given. The recommendations will come out, but it really is going to take all of us in this room and beyond to push and to say that our children definitely are a priority, that they're worth it, and then some for us to get it done.
Thank you for that. Doctor, do you want to respond to what you just heard? Does that, and Zach too, does that get to what you see as the major issues?
Definitely. I think, you know, from my perspective, I feel like I'm in the office.
I feel like I'm at home. All of my children are a little older.
I think just in my thinking about this and, you know, and also seeing you, we have a really important job as clinicians and whatever it is to recognize that we aren't just care delivers, we're witnesses. And we are people who are a part of this narrative change that needs to happen. I went into medicine not because I loved science, but because I was nosy and I loved being in people's business and like learning stuff about, and I think that has served me well in the sense of thinking about the fact that we have an intimate role that some of us forget, that people are disclosing things that they would never disclose to anyone. And with their permission, being able to see things. And our job is, a lot of these people will never make it to Albany, will never make it to DC because they're just trying to live their lives.
Right.
And so if we have the privilege to be able to have that bandwidth, that our role is to take the information and as clinical practitioners, add the face, add the story, add the person, and humanize the fact that these aren't numbers. It's not 1 in 4, 1 in 3. This is this person. This is her story. And so I think about this, and I think about this in different ways because you've heard the number 1 in 5. But then I think about when we disaggregate and we think about Black single mother households, and that's 1 in 3. And we think about it's 40% in Latina single mom households. And so it's really important, I would say, for us to remember like how precious this work is, not just in serving this, but being able to take what you have and turn it into how can we change it through either policymakers, people who are working outside of just the office and bringing those stories to life. I think
Mhm.
that's the really important part of this work, in addition to all of the other things, but
Right.
really important.
Right, Zach?
Yeah, what I'm taking away is, you know, equity, it depends on access, and there's no access without trust and that trusted, relationship. And how do we create a society with as many of those trusted relationships in it as possible? And um, in listening to the policy priorities that Allison was referencing, and trying to think about the work that we're doing and how can kind of Medicaid become a more trustworthy system as it begins to address um, people's economic circumstances more and more. Um, you don't, um, a doctor can be a very powerful person. A doctor is a mandated reporter. You talked about these things. Now we're talking about asking people if they can put food on the table, if their housing is secure. Right? So how do we do that without harming people?
Mm.
How do we do that in a way that is trustworthy? And we were really thrilled that in this Medicaid waiver, children with chronic conditions, pregnant and newly parenting families, and youth with chronic conditions or who are a part of the family welfare system were included as eligible populations for these new resources, because it's critical that introducing the right resources at the right time for these families can be transformative, as we've heard from your story. But that needs to come from a trustworthy source, as it does for you, right? So as we're building the infrastructure, and as we're building a network of service providers, we need to make sure that those trusted organizations, those trusted community health workers, and the ultimate beneficiaries of the services themselves are engaged and a part of, included in the process from the very beginning. So one of the things I'm really excited is that for over a decade, Public Health Solutions was trying to better coordinate access for maternal and child health home visiting. And this is a trusted relationship. A home visitor can be a nurse, can be a community health worker that is with you across your pregnancy and up to 3 or 5 years after the birth of your child. It's sometimes the one continuous relationship that a person may have through that time period. And the maternal and child health funders couldn't get it together to make this happen for because far more pregnant people are eligible than receive home visiting. And there are also underutilization of home visiting for different programs. They're kind of unable to solve this. And so as we build this social care network, I don't like the term. You can probably tell I don't like the term. Community resource network. As we build this community resource network, we can do the prenatal sort of assessment that we do to connect women to home visiting. And now we can add the social determinants of health to that assessment, and an additional set of resources to connect people to, but all through the same kind of trusted home visitor or community health worker. The integration is hard, but that's really what Public Health Solutions is focused on right now.
Zach, I'm so glad we have your brain working on that. Thank you for all of that work. Kate, did you want to open up for questions? Would you like to comment? Would you like?
Yeah, I mean, I hope people do have kind of questions and comments. One of the things that this has me thinking about, and I'm particularly in the context of this, Zach talked about the waiver and the commissioner talked a bit about the waiver, where, you know, the Medicaid dollar will be allowed to be used for logical reasons, right? On things that aren't medical care and that sort of thing. But I think one of the things I think about a lot is we have this long history of screening and testing people. You know, we used to like screen for breast cancer, but not provide funding to cover the treatment. You know, like, and right now, still, we do a lot of, and I say we, sort of we as a society, we, you know, so now there'll be a social care screen now. And I guess I'll just say, I wonder how we are going to not just do the screen. And how do we figure out, how do we really make sure that we do the next thing, which is what we really want?
I wanted to just add too, in response to, Zach, you were talking about the home visiting program and other practices like that. We also were successful, I guess, sort of year two in raising the minimum wage, because all of these jobs that we're talking about,
Right.
and we had a lunchtime conversation with my neighbor up there about, you know, community workers, navigators, home help, like have to be paid a minimum livable wage.
Right.
Otherwise, we're really just having it on paper. As I know in Westchester County, we have agencies that have home visiting, but they can't find, right, the staff because people can't live on that. And it's the same thing with childcare. It's the same thing with Head Start. But I realize that has not been part of our conversation today, employment and wage, and what that means for people to go into these positions that we all know are so important.
And I just want to say that while this work to reform Medicaid is incredibly important and can be incredibly life-changing for a narrowly defined set of people, it is not the big policy structural reforms that are required to meet your goal to reduce child poverty. And what we're really doing as a society, because you know, what's incredibly frustrating is that we don't have the political will to adequately invest in the social safety net. So we have to do this is a workaround. We can't get the political will, so we're going to do what we can to chip away the healthcare dollar and put it in a better place. So I'm just going to acknowledge that that's what this policy is. That doesn't mean we can't make the best of it. We can't make the most of it. We can't create the best and most trustworthy access to it that we can.
We need to do all the things, right?
Yeah, all the things.